is our next speaker is Dr. Maddie, Borhani from ResMed, head of strategy and innovation there at ResMed. Previously, Maddie had been the assistant director of NHSX in technology and healthcare digital productivity. Dynamic, versatile, and visionary leader, she has extensive experience delivering digital transformation programs across health and care. And as an experienced chartered engineer and medical equipment specialist, she also has comprehensive knowledge and expertise in design thinking, process mapping, and service improvements. And then our third and final speaker will be Dr. Adam Dubas from the UCL Global Business School for Health. He's an associate professor. Adam is an enterprise-minded educator specializing in imaging and health data analysis. He started his career in the United States, studying biology and chemistry and participating in his university's health entrepreneurship courses. And upon graduating and entering graduate school at the Medical College of Wisconsin, his background mixed with engineering, resulting in commercialization of several analytical tools and methods for ophthalmology. He moved to London in 2013, and he has continued his enterprise activities, consulting for several startups, as well as commercializing health analytics through patient filing and spin-out companies. So I'm really excited to have these three individuals with us today. And we're going to start with Stuart, who's going to speak to us first. Each speaker will have 7 to 10 minutes to give us their view on this topic, and then we will be opening up to questions. So you'll see that you have a Q&A function, and if you could write in your questions, you can start writing them as the speakers speak. I will then use those questions and we'll get a discussion going with our speakers. So please feel free, you don't have to wait to the end till all three speakers have finished. As your questions come up, please write them in the Q&A. So without any further introductions, I'd like to turn it over to Stuart. Thank you.
Thank you very much, Nora. It's a real pleasure to be here today. So as you mentioned, I have about 10 minutes before my fellow panelists each present to you on this topic. And given the short time frame, I'd like to focus on a few important messages rather than cramming hundreds of technical facts into a talk that probably most won't remember. And so instead of a complicated explanation of a technology, I think it is much more valuable for me to outline briefly what blockchains are in their basic form, why I believe that they are such valuable tools compared with current solutions, and why the future of healthcare, in my view, absolutely depends on them being adopted. So today's webinar is primarily focused on electronic healthcare record interoperability, but I hope to illustrate the point that by using blockchains as the underlying foundations upon which healthcare data is built, we'll be able to create a robust data economy that benefits all stakeholders in the ecosystem, particularly patients. So blockchains at their most basic level are essentially read and write databases, which are shared by participants in a network. And copies of the database are distributed between the participants. And any additions to it cannot be made without network consensus or agreement that the content is valid. And once added, the database cannot be changed. So each time content is committed to this ever-growing database, the changes are linked cryptographically to the previous version of the database, which then remains visible. So what we have, therefore, is a current, always accessible version of what the network accepts is the most valid record of the state of that data, along with a tamper-proof log of all of the changes that resulted in that current state. Now, the rules of governing the database are agreed by the participants in the network. And what this means is that content owners or creators can use, for example, smart contracts to control access at a very granular level. And so what we find ourselves with is a ledger implemented as a replicated state change machine, or rather as a communications channel implemented as a peer-to-peer database, which doesn't require an intermediary for consensus. And this allows multiple entities with potentially diverse economic interests to be able to collaborate where it might be natural to cheat or seek advantage. And it enables us as the reader, when presented with information, to self-verify the author and content of a record, the state before and after each record, and whether that record is complete with no omissions or additions. And so if we take Bitcoin as an example, as the first use case for blockchains, it allows us to be able to transfer a digital financial asset peer-to-peer without any third-party intermediaries across borders in a censorship-resistant network without permission from a central authority. And we know that the asset is valid. So if we were to take that and say a healthcare blockchain then allows us to share an information asset peer-to-peer while retaining custody and near complete autonomy of the asset. It also allows us to provide and revoke granular access controls using cryptographic challenges and proofs. And through digital immutability, it offers timestamping and transparent auditability, all the while trusting in the origins and the veracity of that data. And the key word that we need to take from that is trust. And as we mentioned with Bitcoin, we know that transactions cannot be confirmed into the current state of the ledger until consensus is reached that the sender had sufficient funds, has only spent them once, and that they have a valid recipient address that has taken ownership of those Bitcoins. And that we note that there are no banks involved in intermediating, and reconciliations are instantaneous. Whereas if we look at information assets, these can similarly be transferred peer-to-peer without the need for a central authority. And rather, the owner of that data can grant permissions to another network participant, making the data immediately available. And the fundamental difference from centralized systems is that the network participants can agree to share data by joining this ecosystem, the governance of which is enforced through agreed protocols, and the veracity of which does not rely on a single authority, but rather through the consensus reached for data input. Well, so what, you may ask? We know that healthcare has become much more patient-centric and healthcare consumerism more prevalent. And patients are increasingly choosing to move between public and private systems and interact not only with national health services, but also with insurance companies, for example. But even within an NHS-type system, the ability to exchange healthcare data is critical for patient care, administrative efficiency, for commercial relationships, and for the advancement of science and research in general. Because data is the currency of healthcare. Clinical outcomes depend on its availability and accuracy. The financial efficiencies depend on it. Public health interventions are impacted by it. It's necessary for streamlined supply chains. And scientific research, clinical trials, and even the training of machine learning or AI algorithms demands clean, structured data sets. Now, about 30% of the world's data by volume is generated by the healthcare industry. Yet IT investment in healthcare is among the lowest of all industries. And the potential value from data is immense, both clinical and financial. EY published a report in 2019 saying that the UK's NHS data alone is worth £9.6 billion per year. And big data in healthcare is estimated to be worth $78 billion by 2027. A BIS research estimated, and this is staggering, that the immediate application and integration of blockchain in healthcare could save more than $100 billion per year in costs related to IT, operations, support functions, personnel, and health data breaches by 2025. So we see health data economies are valuable. And in 2021, the World Economic Forum published a framework exploring the key components required to build a robust health data economy. And it discusses the enablers for a data exchange ecosystem with availability, usability, and trust via a multi-stakeholder approach being essential. The document stresses the governance of that exchange as well as the incentivization of data sharing. And of all the tools that we have currently available to us, I believe blockchains offer many of these essential features. Now, adoption of blockchains, however, requires a very different paradigm from the one that we have previously experienced. 5 of the 1,200 or so electronic healthcare record providers captures 80% of the market. And this, I believe, poses a significant barrier to data sharing and interoperability, in spite of legislation mandating it. And you see, blockchains are network and governance technologies primarily. They facilitate, through common shared infrastructure, the mechanisms by which co-opetition can flourish. I like to think of them rather less as toll roads, but rather more like public highways, where everybody contributing to their development and maintenance, but coexisting as competing entities on the road. And like roads, data sharing mechanisms, in my view, should be viewed as public goods. We know that data generators and owners are increasingly demanding sovereignty over their data, and trust in centralized authorities and healthcare oligopolies is diminishing. Data sharing, appropriately governed and incentivized, I believe, benefits all stakeholders. And blockchains provide the foundations for a trusted, secure, accessible, privacy-preserving economy, data economy, to flourish. So with pre-agreed rules of engagement, smart contracts automating business logic, and cryptographic ownership and permissioning mechanisms, the real question in my mind is, why have we not adopted this more? Thank you.
Thank you, Stuart. That was really helpful and a great start. I'm now going to move to Maddie.
Thank you, Nora, and thank you so much, Stuart, for giving a great introduction to our discussion today. So what I'm planning to cover in my conversation today is firstly highlighting what do we mean by health interoperability, highlighting some of the challenges and benefits associated with having interoperable system in the NHS or any health and care setting, and also highlighting how blockchain could be an answer to some of those challenges that we are currently facing in healthcare setting. So in terms of interoperability, what it means is the ability of health information systems to work together within and across different organizations so that we can advance an effective delivery of care, not only to individuals, but also to communities as well. So the idea is to have one single true version of a person's medical records. So I'm going to use NHS England as an example. We have got a number of electronic health records providers across the NHS and also across some of the social care settings. But we also have many organizations that they do keep patient records in completely different formats. It could be paper format that they usually scan and upload into a server. They create files and folders per patient, and they use that as their healthcare records. So as you can see, we have got different systems, providers to hold those information, patient information across different healthcare settings. So the whole purpose of interoperability is to bring the whole system together so that we can access the patient data across different healthcare settings, so that we can not only improving the quality of care, but also improving patient experience and staff satisfaction as well when they are providing that care to the patients. So the point of interoperability is accessing the most up-to-date information about the citizens as well as patients, regardless of what system is in use in health and care setting. Therefore, having the bi-directional connectivity between systems in real time is quite essential to support health and care professionals in delivery of an improved and safer care. So there are some benefits associated with that. It would help the clinicians to make an informed decision for their patient because they have got access to the right data at the right time, which means that they can reduce some of the duplication of effort and provide that seamless transfer of care between different settings, which means when a patient gets referral from primary care to secondary care and maybe from secondary care to another specialized care, those information are easily available to the clinicians to make the right decision at the right time. So that really means that we are providing that patient-centered care service, and ultimately means improving patient care and their experience as well. So there is no doubt that having an interoperable system is quite essential and important for providing that care. But then there are some challenges currently in the system that doesn't allow every single organization to be able to transfer or have that direct communication between different systems across different organizations, across different settings as well. So one of the challenges could be the current fragmentation and divergence across some of the healthcare settings, this is really a barrier to develop a true digitally enabled integrated care services. We also have got an issue in terms of overcoming organizational resistance to sharing data. It could be a system-driven mindset or approach, or it could be suppliers-driven approach, just because of some local politics, unhealthy competition, which is one thing that Stuart just mentioned around blockchain that would creating that highway rather than being a road toll. So I think that really resonates here because of some of the politics, some of the competition in the market. It makes it really difficult for the system to integrate and create that connection and transfer of data or interoperability between different systems. The other aspect is the evolving regulation and standards and also the policies. So there are a number of standards that has been set, especially since COVID. COVID has been the catalyst for digital transformation, specifically in NHS. But as back of that, many regulations have come into place, such as DTAC, Digital Technology Assessment Criteria, that covers interoperability as well as one of the main factors. There has been introduction of open standard as well, and also some policies that has been created by NHS England. But because we are facing a lot of competing priorities right now with NHS, there is not an easy or digestible approach for suppliers or even for the healthcare system to understand and adopt those policies and regulation. It's a huge barrier in terms of how are we going to move towards those digital transformation and create that system interoperability within health. So blockchain could be an answer because it provides that secure place that the data can be shared. It allows the patient to have their data information as a wallet, so that everywhere they go, they have got their healthcare records with them, so that provides the patient with the power to control their care, and also they have that a participatory factor as well in managing their care and supporting their changing their lifestyle and making sure that they are doing the thing that they should be doing in order to improving their health. So blockchain could be an enabler for system interoperability within health, but there's a biggest factor and enabler here by implementing blockchain, and that's really focusing on a better population health management. So we know that we are moving towards the big data. All the data are quite important for clinicians to make the right decision for the patient. But at the same time, we are moving towards a more proactive care rather than a reactive care. To provide the proactive care, we need to have access to the right data. The data could be health, it could be care, or it could be social determinants related to that population or that specific conditions to allow clinicians to make the right decision and create that proactive approach. So having a health blockchain-based approach will improve communication and coordination as patient transition across multiple settings of care. So all of that information that use or the clinician come across during, let's say, primary care, secondary care, and specialized care, and also social care, that would allow them to have that right communication between the system so that ultimately the clinician can develop and implement an effective longitudinal care plans, especially for the patient who suffers from long-term conditions such as respiratory care or cardiovascular, musculoskeletal diseases. These are the costly conditions because of its long-term impact. It's going to be very costly. So using blockchain, having that interoperability, safe environment to transfer and share those data with the right setting would enable those proactive care and personalized care that clinician can provide to the patient. And that means, for example, with a patient who are suffering from COPD, you can estimate or predict based on the data that you have got access to, the right data. You can predict their exacerbation rates, which then eventually means lower A&E admission, lower length of stay in hospital, and all of that consequently would have an impact on the health economy as well. So there is economical gain there as well to be able to use the right data and having that interoperability within the system. So just to summarize, we have spoken about the blockchain and some of the impact that it can have, especially in terms of where we are moving the future of healthcare, that 4P, the participatory, predictive, preventive, and personalized care. So blockchain could be an enabler, but we just need to think about the challenges that we might face to bring that change. It's going to be a huge change. And having that experience within the NHS, it's really important to be able to manage that change by bringing the right foundation within the system so we can implement such technology more safely and effectively in a shorter period of time. So that's me, Nora. I'm going to pass over to you.
Thank you, Maddie. That was really helpful and answered a number of questions. So lastly, I'm going to move to Adam.
Thank you. So thank you, Stuart and Maddie, for setting up so well. Wrapping up here, I'm looking to share sort of 3 different areas where interoperability can actually help you with some very specific changes that this could bring to healthcare. And then go through a couple of examples of places where blockchain is being applied where businesses are rapidly growing. The first one is, think if you and your friends are out and something happens and you need medical care. How does a doctor know if you have something like a latex allergy or a penicillin allergy? 2 very first run frontline treatments for any sort of infection or just medical care in the form of latex gloves. Currently, it's estimated that 9.5% of deaths in the US are because of medical errors, because the information is not provided to the doctors at the time that they need it. And that number at just shy of 10% is in a fairly digitized healthcare system. Those numbers go up with the lack of digitization in any given health system. So having the digitized health records, having it accessible and able to follow you means that the people that you are, that are seeing you are going to have the information. And this is going beyond just a single healthcare system, the doctor that you attend. This is interoperability at the level of full healthcare systems, or even something as complex as maybe carrying it on with a chip or a little barcode or a little RFID tag that you might see that is able to link everything together in some sort of wearable. So no matter where you come in, even if you are not able to communicate, that information of your healthcare, especially the high risk, would come through. And again, using blockchain, that this would come through in a trusted and interoperable way that anyone would be able to read. The second one is to increase efficiency. And through as healthcare is constantly expanding, especially the world that I come from of images, we're able to document everything in healthcare so much more. Even just 15, 20 years ago, doctors would frequently rely on sketches into your notes to document what something looks like. Now we have cameras that are able to analyze in 2D, 3D, 4D, maybe even come up with 5D if you start looking through time and space and color. And there's so much information here. It's how do you report that? There's been so much work if you've worked in the health system of DICOM standards, but the data has now grown beyond those, and we need new interoperable ways to do this so that that information can share. The specialist, and also to allow from one specialty to another specialty to use that information. So it's very important, again, that this data is going to be transferable from place to place, so that you don't need to have a second set of scans just because you went to a new doctor. That the information was acquired once, making sure that it stays seamless and is able to be improved. The last one is patient security and also improving patient experience. You think about, you go from one doctor to another and you go through the same questions. What is your medical history? What has happened to your parents? What has happened to you? Think if you can remove that and the doctor would have that information available to you right away. We've all read about some of the major data breaches where large amounts of health data was made accidentally available, or even in the ransomware attacks that happened to NHS a few years ago. The encryption standards that follow with many of the blockchain protocols, it allows the data to be kept more securely and as well as being portable. So in improving the experience, but also increasing the security of the data. So those are three real world examples that these sorts of technologies could bring to you and helping to improve your medical care. Now, uses of blockchain. Stuart mentioned the supply chain. Making sure that hospitals know exactly where they have and where they have it. Think of all the medical devices in a hospital, even things like IV racks and medical dispersion units. These things are highly portable. They're constantly moving around. Think of a system where each one of these things is tagged and linked into a system, so that as the next patient comes into an acute care facility, the doctor can look at the system and look at where are all of these things. What room is it in? What condition is it in? Has any maintenance issues been flagged to it? Being able to have supply making sure that all the materials that are needed in a clinic for a given day, given who's coming through, having this sort of information available. Making with a blockchain that also puts you as the patient in control of much of your data, that's saying that your patient, or saying that your doctors would have. You are able to go through and make sure that everything that you reported is present, make sure that it's accurate, and make sure that the doctor that you're seeing is going to have that information available to you. A huge growth in the blockchain use is in clinical trials. Again, think of many of these multi-morbidity conditions, heart disease, diabetes, that are frequently linked together. Being able to have the information available at all the sites being able to verify the information be put into that, ensures that the data that you have is more accurate, ensuring that trials can be much better powered and much better put together. And then you add in things like the next generation of research, trying to improve all the information we know about health and trying to improve our policies and practices. And really the greatest value to a blockchain technology is really limiting the amount of data traveling, because it's all stored on the central server, and therefore minimizing the loss of time in medical care as well as cost. So I hope that you can see that there's many advantages to you as an individual for the move towards interoperability, ensuring that your care and your experience in care is better, and many different areas where the expansion of these technologies is showing growth in the medical health space. So thank you.
Great. Thank you so much, Adam. So really a great introduction to a really important topic. I actually want to, we've got some questions that have come in, but I want to actually start with the last question first that's come in so far. And that is about really what is realistically is the scalability of blockchain for the amount of medical data. And how would you, Maddie and Stuart and Adam, how would you approach healthcare providers and PPIs to adopt this technology within their networks? I mean, it's just as an aside, we know here in the UK, the NHS, it's not for not spending a lot of money trying to bring about interoperability and some of these things. So the other kind of caveat I'd like to add on here is, do we start from, data zero? Do we move forward, or do we try to move back and capture everything that's already captured about an individual to really start to develop these systems and move forward? Because I think, there's the interoperability piece, and then there's the how does that relate to blockchain and the scalability? So who'd like to go first?
I can cover the section around the scalability, and especially when we are talking about interoperability. I think this is one of the biggest challenges that NHS is currently facing with any type of technology that has been studied, piloted, implemented in NHS. The final question was, how can we scale it? We are not that great in scaling some of the technology that we have so far managed to implement within the NHS. And again, that goes back not only about the cost aspect, it's really about bringing the system together to work as one united system. So in terms of the scalability, there are many questions considering, is this a local need, which is really covering that organization, that trust and the primary caring setting around that? Is it really about the population, which is around integrated care systems? Or are we talking about the regions, the overall population in a specific region, let's say south of England or north of England? Or are we talking about something national? So as you can see, there is 4 layers of hierarchy within the NHS. So scalability has always been an issue, a challenge for any type of digital transformation that we have had within the NHS. There was an IT program whiles ago that the idea of that was to connect all the healthcare systems across the whole NHS at national level in England to allow clinicians to have access to the right data, but miserably failed because they didn't have the right buy-ins from the right stakeholders, and highlighting the value that those technologies would bring not only to the patients, the citizens, but also to users of those systems as well. So it's really difficult to, we can speculate on many factors, but it's really about the whole ecosystem to work together. So having the senior leaders at national level, regional and local level to come around with the suppliers, talking about the best way forward, that whilst they are protecting their market share, their own kind of business, but at the same time, how we can work together to scale such new technologies such as blockchain within the NHS. And what else? What was the other part of the question, Nora?
Well, it was really about that, the scalability, but there is the follow-on question about, you've got all these electronic health record providers. You've talked about just the challenge of really getting interoperability. So are they up for moving to blockchain, and how would blockchain change the situation you just described?
Maybe Stuart would be in a better place to answer that, but from from NHS, if I look at it from NHS's lens, we do lack evidence and in the long-term impact of blockchain. These are the tangible evidence that they can highlight how using this technology would improve quality of care, how would improve quality of service, and many other societal benefits as well. So lack of evidence, I think, would be one of the barriers and challenges to bring the system together and push something similar to blockchain to the system. But Stuart, what do you think from your perspective and this expertise?
Yeah, it's interesting. I think that probably the best, I mean, because blockchain is a governance technology primarily, and nobody can exist on the blockchain on their own, if you like. It's not a single person thing. It's an ecosystem that is by design helps collaboration. And so in order to be able to collaborate, you have to agree the ground rules for collaboration, which is setting up the governance structures. And so the whole start small, think big, scale fast kind of paradigm is probably where I think the best approach would be, which is, get the smallest minimum viable network in the room. So, what is the smallest network that can make this work on a small scale, test out a single use case, prove the value, have the metrics for it, and then demonstrate that to, further people, as you go further out. And I think adoption has to be sort of that way.
I think just adding to that, I think you really hit it well, Stuart, is that there is going to be levels here. There is the individual level where the person needs to have major health concerns, again, those sort of allergies, those morbidities, that was instantly portable, something like a credit card that someone would always have on them, where versus complex care that is largely within a single hospital system, between sub-disciplines. So the amount of data being held at those different levels is vastly different. And I think that we're moving forward, that we definitely have to have a couple of proof of concepts. The idea that you brought up, Stuart, of clinical trial use, again, a very specialized, very small network of people that need data. I think making some proof of concepts there definitely shows how immensely useful it is going to be, and then also points to how to make this scalable across a larger health system. So, you're right. Yeah.
Yeah, I wandered out of the room. And so look, I think let's take the next question. And so how would we fund blockchain? How do we get this? And I think particularly we focus a lot on the NHS, but if we start to look to lower income countries, there's an opportunity for those countries, where people often have less access to public health, and often are paying out a pocket private clinics. What could that look like?
So I think that one of the easiest ways to implement technology, may not be the best, is looking at some of the losses. So as I mentioned in my piece, is the amount of deaths caused by medical errors, which is probably the most horrific end of it. But you just look at the number of medical errors resulting in additional surgeries, or resulting in some sort of agreement between the person who was wronged and the healthcare system. You looking at those sorts of sources of revenue and seeing how much of those could be reduced by the sharing of information, and trying to leverage some of that revenue as sort of a first step in trying to find the money to fund these sorts of technologies.
So what do we think it would be the time frame? Do we, I mean, we're talking first about interoperability, and you mentioned regulations, and I would love the idea that I can walk around with my digital health data, and I can do it with my financial data. I can check my bank account anywhere. I can access that. Stuart, you mentioned that, some really, fascinating statistics about how IT and healthcare is lagging behind so significantly. I find it really shocking when I think about how important and integral our health is. And then also the fact that spending in health and healthcare is going up at an exponential rate. And most of that spending is not what people think is just aging populations. It's actually technology. So how do you make sense of that?
Well, I think the rise in spending in healthcare is, at least to some degree, is through the increased costs of administration and the complexities of administration. And so, something like a blockchain system, which, we're talking about electronic healthcare records and interoperability, and I think that's an important piece. But I also believe that there's an enormous opportunity, as that BIS research suggests, $100 billion a year for reducing IT costs and support functions and all the other administrative functions which are also in silos. So I think there's an opportunity there.
And is there any example, it gets back to what Maddie said, I think in persuading, the healthcare sector, they need evidence that this is doable and it can work. Do we have any evidence? Is there any provider in the UK who's pursuing blockchain?
I'm not sure whether my colleagues on the panel have had UK experience. I mean, there are companies. I was involved in one in the early stages, 2017, looking at electronic healthcare records and blockchain. There's probably 25 that I found in some research, globally, looking at just electronic healthcare records and blockchain. And some of them have started to gain significant traction. I spoke to the CEO of Patientory, who's one of the examples in the US, and she's been building. It's been a long slog, 5-6 years, but she's now managed to design a framework that enables 24,000 US hospitals to come on board and join the network. So it's a slow process, and I think the idea is good. The technology is probably relatively immature, so I think there's a bit of a lag in terms of adoption from that point of view, because we have to deal with, as we mentioned, privacy, which we can do, scalability, speed of transactions, but sufficiently decentralized to be secure, and permissioned, not public necessarily, blockchains when it comes to patient identifying information. So the technology is being tweaked and it's improving day by day. I mean, you couldn't keep up with a single aspect of blockchain, and in this industry, 5 minutes goes by and you're kind of out of date. So things are progressing massively, but there's still enormous amounts of funding going into blockchain. And of the small trials that have been done and the small commercial successes, I think there were 10 in one paper that have gained commercial success. I can share all the details of papers with viewers if they're interested. But there's some good evidence for some commercially viable blockchains in healthcare which are gaining traction. So I think we're not quite there. I think that it's a case of just if you look at even take cryptocurrency as an example of blockchain, there's probably only 200 million users globally that have got Bitcoin wallets, if you like, and from an 8 billion population, that's tiny. I think we're quite early in the stage of this technology, and I think give it another couple of years and it'll be exponentially more. But as we've sort of discussed before, I think it's a consortium technology. It's a governance technology. It requires a network. It requires collaboration. So really and truly, it's a think we, not I. It's a start small, pilot where you can agree a governance structure and mutual benefits, measure those benefits, and measure the risks that you think you might be facing that you haven't faced. I mean, there's good examples in the UK of blockchain-enabled supply chains in the healthcare industry that are doing incredibly well, and have made enormous cost savings and efficiency gains. And so I think that just needs more visibility.
Great. And Maddie, let me ask you a little bit of a controversial question. Do you see this being driven forward by private companies? I mean, right down to just electronic health records and interoperability. Is it going to be more driven by the private sector, public-private partnerships? I mean, we've seen, of course, the NHS investing a lot of money. But what do you see on the kind of private scene in terms of where the interest is and how they might fill some of that gap?
It's a very tricky question to answer. When it comes to novel technologies, as I mentioned before, NHS is always not the first organization who would risk to uptake or scale or even implement those technologies, because the appetite risk is quite low. So I'm going to use an example: robotic process automation, RPA. This is a simple technology that has been out there in many industries for over 20 years. There are many evidence to highlight how beneficial it is for any system to improve efficiency and productivity. To be able to implement that in NHS to the point that we can get national funding to invest and spread across the whole NHS England, it took over 7-8 years. And look, this is a technology that has been there for quite a while. It's not something novel. But here we are talking about a technology that, first of all, we don't have a lot of evidence to highlight is how it would impact the quality of care. This is the tangible evidence, highlighting the value for money. So it requires a huge investment at the beginning. We have got a lot of legacy system. We have to work with the system in terms of the resistance to change, the whole change management, upscaling the staff in using those technology, the regulation aspects, all of that. If we combine all together, it would be really difficult to be this technology being driven internally from NHS itself, but it needs to be driven mainly by suppliers to highlight those benefits, those tangible evidence that they have created by working across other industry or other healthcare system across globe, and highlighting how would then that impact NHS in solving some of the current crises that they are facing in terms of efficiency, the errors that are being made, all the liability that they're facing. And again, one great example would be the crisis that we just had in terms of freeing up beds because they couldn't discharge patient to the social care because there was no place, there was no communication, direct communication between the two health settings. So this could be a solution for that problem. But again, we need to highlight it. We need to speak the same language to highlight the cash releasing benefits, non-cash releasing benefit. And government sets a return on investment threshold, 1 to 4. For every £1 you spend, you need to showcase that you're saving £4. So how can we do that with blockchain? So I think this is the language we need to use to work with NHS leaders, individuals within the NHS. Again, if we are thinking about the testbed, small pilot sites, these are the language that we need to use to bring that attention to the saving that they can create. And some of those saving might not be cash releasing. You're not going to be saving money, but you're going to save so much hours. You're going to improve quality of service and care. So I think it's just navigating that kind of relationship between suppliers and also the NHS, and what language to use and what benefit and evidence to use is quite crucial and important to bring the change into NHS.
Thank you. And Adam, going back to the patient, because these words like interoperability and blockchain, and as Stuart just pointed out, it's a fraction of society that, even when we talk about Bitcoin and these things as being, something that's risen significantly in a short period of time. So, where do patients fit in here? I would wager to say most patients don't really stop and think when a medical error happens that it's because of lack of interoperability or the doctor not being able to get the right information. And but we hear so much today about patient-centered care. So who should be championing this, as Maddie's pointed out? Is it the system itself? And where do patients fit into all that?
Well, I think patients are going to have multiple roles in this. The first one is going to be looking at leveraging the patient frustration. Any patient who frequents different clinics, is very likely to be talking about how they need to repeat themselves every time. You hear the complaints frequently in the news these days in the NHS here of, every time I go to the GP, I'm seeing a different doctor. I need to read, go through everything, talk about all my history, talk about my problems, talk about everything that we've done. So, those sorts of things, you're right. It may not echo into, the fact that there is a health problem, but just the repeating of time and, oh, I have so little time with my doctor. I'm just repeating the same sort of information each time I go. So leveraging those sorts of frustrations with potential solutions through interoperability, I think is going to be one way to help people engage. Is it engaging in interoperability? No. Is it improving patient experience? Yes. And I think using terminology of patients, improvement of their experience of the doctor is going to be where it's going to improve.
Okay, so I see we're out of time. So I just want quickly to go around and ask each panelist, what's it going to look like in 10 years? So, Stuart?
Well, I'd love to paint a very rosy picture, and actually, I think there is huge opportunity. Even especially if you look at the UK, which has, I think, quite a unique opportunity in the sense that it has, a single system, a publicly funded at the currently healthcare system, and 65 million patients whose records are, I think if the opportunity was seized, I think there is an enormous health opportunity, financial opportunity for the UK. All the pharmaceutical companies in the UK that could benefit from data, and the country could share in those spoils. I think the technology is accelerating at an enormous pace. I think maybe that the paradigm of human interactions is shifting. I don't know whether we want to go deep into authoritarian regimes versus socialists versus the current state of the world. But I think the mental shift is changing globally. I think patients are becoming more interested in sovereignty. I think data privacy and protection is becoming more of a thing. Nobody wants to have Facebooks and similar entities sort of controlling their data, and I think that applies to healthcare too. So I think it's probably maybe 5 years, in the making, but I feel like the paradigm shift is changing, and that collaboration is a much more powerful tool than what we've been doing in our version of capitalism so far. And so that whole African proverb of, if you want to go fast, go alone, and if you want to go far, then go together, I think that applies here. And I think that blockchain is a foundational technology that is infrastructural. It should be a public good in some respects. It should, it's just a case of small groups of people testing it out and proving the concept and using what Maddie suggested as you find some appropriate metrics, and I think the evidence is mounting. So I remain hopeful.
All right, thank you, Maddie.
I think it would having a digitally enabled integrated care services that would allow us to provide that personalized and proactive care to our patient in a very secure way that not only would improve the quality of care and the service delivery, but also improve the workforce satisfaction as well, so we can overcome the workforce retention, all the issues that we are facing currently. So having these technologies and considering the rate of adoption in the last 3 years and rate of digital transformation, I don't think, I think we would be able to get to the place that we have got those, the ability to utilize the big data, all the data that we have got across the health. And then hopefully after that, we can think about how we are going to leverage blockchain and other technology or similar technology to expand that across horizon and support the patients in a more informed and better way.
Okay, great. And then Adam?
So I think that the technology push, it has to be successful. You look at the engagement of people in their own healthcare over the last 10 years, things like, wearables, how many people have a Fitbit, how many people have a smartwatch, how many people are addicted to making sure that all of their metrics on said device are being successful. You look at many insurers around the world, using these to reduce people's premiums based on performance on those. People are becoming much more engaged with their health and their medicine. People carrying their health records with them to ensure that everything is being accurate and transferred from place to place. Providing people with the solutions to have this where they don't, where they are a part of it rather than being solely responsible for it is definitely going to have a lot of traction growing with people. So I don't think it's a matter of if, I think it's just a matter of when.
All right. Well, thank you so much for your time. It's been great listening to you, and I'm cheering for blockchain. So I think it really could revolutionize the way we think about our health as well as our healthcare and data. So I'm really grateful to you, Stuart, Maddie, and Adam, and everyone online. Have a great afternoon or evening wherever you're at. Bye.